So what I want to talk about is what evidence is actually being used at the moment from an English perspective to think about whole genome sequencing. One of the big areas of debate at the moment is how we should be using whole genome sequencing in routine practice. And this slide will be familiar to many people, and this slide shows that the costs of sequencing have come down dramatically over time. And this slide was initially prepared by the NIH in the States. But what this slide doesn't show is that the costs of bioinformatics and other components that go along with sequencing, those costs are certainly not reducing at all. So this whole idea of the $1,000 genome at the moment, I would say, is still very much a myth. And James will talk about that in more detail. So in terms of what the evidence is for whole genome sequencing, or even whole exome sequencing from an economic perspective, the evidence really isn't there at the moment. Okay? So we did a literature review last year in Oxford looking at economic evaluations in the area, and we found 36 publications. Now, if you put this in context of medicines, there are thousands of publications on cost effectiveness of medicines every year. We found 36 publications on whole genome or whole exome sequencing over a much longer period. And we had a very generous scope in this. This $100, 100,000 or 1,000 figure didn't really exist. The most common outcome measure was diagnostic yield. So qualities hardly featured, survival hardly featured. But yet, these studies concluded that whole exome and whole genome sequencing was superior in economic terms to other testing methods, such as single gene testing or panels. So despite very little information, most papers came to this quite strong conclusion. When we dig down into papers themselves, only 8 of them were full economic evaluations, as health economists we would consider were fairly robust. The sample sizes were tiny, so some of them was only 2 or 3 patients, and there's a real lack of detail on costs. Often just one total figure was provided. So from the review, we concluded that the current health economic evidence base wasn't really there to support the widespread use of these technologies. Now, linking onto this, the 100,000 Genomes Project, hopefully, is a vehicle to collect health economic evidence to look at cost effectiveness, particularly long-term cost effectiveness. In a sense, because besides collecting the data on the clinical components and the genetic components, there's also data on hospital episode statistics, which is a very useful set of information for health economists. And this data is available both before and after the sequencing. But unfortunately, as most people will be aware, there isn't a counterfactual group for the 100,000 Genomes Project. So there isn't a nice clinical trial type scenario on which to collect health economic evidence. There's also no data on quality of life, if you wanted to look at it at all, or other outcome measures of health. So it's very much about diagnostic yield. Now, in terms of how NHS England has been thinking about the economics of whole genome sequencing, I'm involved in an NHS England working group, actually 2 working groups, one on cancer and one on rare disease, where they're trying to figure out which tests are most appropriate to introduce whole genome sequencing for in both the short term and the longer term. And as Ellen alluded to this morning, whole genome sequencing is going to be rolled out very soon in the NHS for a limited set of conditions. So what I've done with NHS England is looked at how they could possibly use some economic information to help that decision-making process. But we aren't using any health outcome data. It's purely looking at a so-called tipping point analysis to figure out at which point is whole genome sequencing favourable compared to other tests. So we've taken a series of different conditions and looked at current testing options and compared it against whole genome sequencing. And for some conditions, current testing has to be very expensive before you'd even look at whole genome sequencing. But the leukemias are an area where current testing at the moment isn't ideal. Some patients is quite costly. So the leukemia patients are probably going to be some of the first patients to have whole genome sequencing in the NHS, along with patients with rare diseases. So the early ones are going to be intellectual disability, because their current testing is very expensive and patients pass around from one specialty to another, and over time accrue lots of costs. And looking at the hospital episode statistics is one way to gather evidence that using other simpler tests, whole genome sequencing, can actually be more expensive than whole genome sequencing. But as you can see, in terms of the current evidence base, there's hardly anything there in the literature at the moment. There is some scope to collect data alongside the 100,000 Genomes Project, but we don't have a counterfactual to the same situation in Canada and other countries. But yet, sequencing is going to be rolled out at scale from October onwards. But over time, more and more evidence will be collected alongside the project. Now, I'm passing over to James now, who's going to go into a little bit more detail on the costing components, because as Kath alluded to earlier, we don't really have tariffs in genomics, so we've had to try and collect our own cost data to provide some information.
Okay, thank you very much, Sarah. So I'm going to build on what Sarah has said and talk a bit about what health economic evidence exists in the literature for whole genome and whole exome sequencing, and then talk about the gaps that we might be able to fill in this evidence base. One thing that I wasn't going to mention was to talk about why health economic evidence is important, because I hope it's self-evident. But I wanted to pick up on one thing that Ellen said earlier this morning, which was that we might not be able to wait for this evidence before we implement this. If we delay implementation, then patients may miss out on the benefits of sequencing. I think it's important to also note that if we make the wrong decision, if we implement the wrong applications of genomic testing, then this has an opportunity cost for the NHS as well, in terms of the non-genomic testing interventions that we can't then afford to provide. So I think it's really important to make evidence-based decisions in this area and include health economic evidence as part of that. So I'm going to try to address three questions, which are how much do genomic tests cost, and what's the current trajectory of these costs? Are they cost effective, and are they valued by key stakeholders in the UK NHS? So as you saw in Sarah's presentation, and as I think many of you, if not all of you, will know anyway, the cost of generating a sequence, a DNA sequence, has fallen quite dramatically in recent years, and now there's quite widespread discussion of the $1,000 genome. This hasn't been accompanied by a great deal of economic evidence on the real costs of sequencing, and indeed Sarah also mentioned, and I think Dean and Catherine have also mentioned, that the costs associated with bioinformatics have not come down, for example. So it's the jury is still out in terms of whether we're actually hitting this $1,000 genome. One of the things that we wanted to look at in the systematic review that Sarah introduced was what estimates of cost actually exist in the literature. And this is what we found. There were 29 studies altogether, and most of them were for looking at the cost of whole exome sequencing. The costs varied between £400 and £3,600 per sample for whole exome sequencing, £1,300 to about £17,000 for whole genome sequencing in humans, and then about £40 to £500 for bacterial whole genome sequencing. When we looked in more detail about when these costs were estimated, there was no evidence that the costs of whole exome sequencing were falling over time, and only very limited evidence that the costs of whole genome sequencing were falling over time. There are only two estimates for the UK for whole exome sequencing, none for whole genome sequencing. Very few studies described how these cost estimates were generated. There was little information on what elements of resource use were valued within the overall cost estimate. Very little information on the perspective that was adopted to perform these calculations. A lot of the cost estimates weren't actually costs. They were either commercial prices, or they were threshold cost values at which point whole genome or whole exome sequencing might become cost effective in the future. And then finally, those estimates that were actually closest to the $1,000 genome or £1,000 genome figure actually tended to be those that were of the poorest quality. So there's clearly a need for some detailed, good quality cost estimates in this area. And that's something that we've attempted to contribute to here in Oxford. So we've recently completed a costing study of whole genome sequencing in the Oxford Molecular Diagnostics Centre. The aim of this study was to estimate the cost of using whole genome sequencing to identify pathogenic variants in either cancer or rare diseases, and this was using the Illumina HiSeq 4000, processing 300 samples a year. So obviously, straight away, that's not at the sort of scale that 100,000 Genomes Project would be considering, but it's still an important perspective to take, because it's not necessarily always the case that this is going to be done at scale. You can see the main results in the table. Actually, the costs for cancer and rare diseases came out pretty close to each other at about £8,000 each. There were slight differences. The equipment costs were slightly higher for cancer. Consumable costs were slightly higher for other way around. Consumable costs were slightly higher for cancer. Equipment costs slightly higher for rare diseases. In both cases, about 50% of the costs came from performing the sequencing step. But there were several steps after that, so reporting, bioinformatics, archiving, which also generated significant costs. And these tend to be costs that aren't included in the headline figures of the $1,000 genome. So in the applications that we considered in cancer and rare diseases, these costs accounted for between 25 and 30% of the overall costs of testing. So the take-home message in terms of costs, I think, is that the evidence doesn't really exist yet to support this, the headline figures, or the notion that we've reached this $1,000 genome figure. The second question I wanted to address is whether these tests are cost-effective. So Sarah mentioned that we identified 8 economic evaluations in the literature review, and all 8 are in this table here. Only the first 2 studies in the list were cost-utility analyses using quality-adjusted life years as the outcome measure. All the other studies looked at number of diagnoses, number of additional or number of positive diagnoses as an outcome measure. The only cost-utility analysis in a UK setting, which was a study by Buchanan, Hughes and colleagues, was actually just a conference abstract, and the evidence suggested that it was more expensive and less effective than current practice, so not convincing evidence really. The only other UK study was by Gurdeep Sagu and colleagues, and this was a cost-effectiveness analysis of the use of whole exome sequencing, and they found that the additional cost per case detected was between £2,000 and £3,000. Again, as Sarah mentioned, a lot of these studies had quite heroic conclusions in terms of the cost-effectiveness of whole genome sequencing. They were quite positive, and that's not really borne out by either the results or the methods don't give you great confidence in these cost-effectiveness estimates either. So there's a lot of methodological uncertainty in terms of how costs are calculated, the measurement of health outcomes. These studies are all undertaken in different patient populations and clinical settings. And I think overall it's difficult to come to any sensible conclusions currently about the cost-effectiveness of whole genome and whole exome sequencing, either in the UK or even further afield than that. So that's all I can really say about the cost-effectiveness of these tests. The third question that I wanted to address is whether genomic tests are actually valued by key stakeholders in the UK NHS. So it's increasingly becoming apparent, I think, that if we want to effectively translate these tests into clinical practice, then we need to better understand and be able to quantify the preferences of key stakeholders whose actions and beliefs are going to be the main drivers or not of the uptake of these tests. And this sort of information, as others have already mentioned, doesn't typically feed into the decision-making process of the major health technology assessment agencies like NICE and their equivalents in other countries. This rather dull-sounding report that was recently published in the USA provides a little bit of encouragement in that regard, because the authors called explicitly for a more widespread use of methods to quantify patient preferences within HTA processes to better understand the outcomes that are of importance in this context. A common way of doing this is to conduct stated preference studies such as DCEs, which Dean covered in a little bit of detail earlier. And these approaches are now becoming more prominent in the USA in terms of feeding into decision making, not so much in the UK, but the evidence base in terms of stakeholder preferences for genomic tests is improving. And I'm going to describe 2 case studies over the next few slides. I was going to explain what DCEs are, but I think Dean has kind of covered that, and I'll do that as I go through the examples anyway. So the first example is a choice question from a DCE that I conducted in patients with chronic lymphocytic leukemia a couple of years ago. These are patients in the UK with chronic lymphocytic leukemia. And the aim of the DCE was to evaluate what the preferences of patients are for different attributes of genetic and genomic testing in this context. And the background to this is that tests were becoming available that could guide decisions as to which chemotherapy treatment patients should be given. The test would provide information on likely response or non-response to chemotherapy. So we asked patients to complete 16 choice questions like this, to choose between 2 tests, and the tests were defined in terms of their cost, how long it took to get your results back, the ability of the test to identify those who wouldn't respond to chemotherapy, and how well the test did this, how reliable it was, the length of time that healthcare providers or health professionals spent describing the test and providing the results, and the type of healthcare professional who provided this information to patients. And the levels for these attributes varied across the different choice questions. 220 patients with leukemia, chronic lymphocytic leukemia, completed the DCE, and as you might expect, even before carrying out the DCE, patients preferred tests that were more effective, more reliable, cheaper, return results more quickly. They also wanted 15-minute appointments, so reasonably lengthy appointments, and they wanted these appointments to be with specialist nurses or consultant hospital doctors. And so far, that is probably as you would expect. One of the nice things about DCEs is that they allow you to quantify these preferences, and if there's a cost attribute, which there was in this instance, we can quantify them in cost terms. So we can also say that respondents are willing to pay about £50 for a 1% increase in the proportion of chemotherapy non-responders that were identified. So there's your primary clinical outcome, if you like, from testing. They're also willing to pay about £150 for a 1% improvement in test reliability, so a reduction in the number of times the test got it wrong, essentially. In terms of process-related attributes, patients were willing to pay about £30 to reduce the time to receive their test results by a day, and about £1,000 to get their results from a consultant hospital doctor instead of their GP. So both clinical and process-related attributes are important to patients in this context, and that's quite an interesting finding when we consider that it's only typically the clinical attributes that would feed through to decision making or to resource allocation decisions in this context. So that's one example of a DCE in patients. The second example I want to show you focuses on clinicians. So I think most times the focus is primarily on patients when we're thinking about stakeholder preferences for genomic tests. And I think that is generally fair and correct. But we should also be aware that it's not necessarily the case that the preferences of patients are going to be the main barrier to the translation of these tests into clinical practice. And the preferences of clinicians and healthcare professionals are also likely to be important. Genomic testing in inherited cardiovascular disease is a great example of a case study in which the preferences of these healthcare professionals are potentially significant. So there are several genomic testing approaches that could be useful in this context. Whole genome sequencing, whole exome sequencing, panel testing are all options in inherited cardiovascular disease. But there's no current clinical consensus as to which is the preferred approach, and indeed there's quite a lot of scepticism that genomic testing is useful at all in this context. So we thought this might make quite a nice example to explore the potential for preferences of clinicians to be a barrier to the translation of these tests into clinical practice. So we conducted a discrete choice experiment that aimed to first understand the relative preferences of healthcare professionals for the different attributes of these tests, and then to use this information to say something about the likely uptake of genomic testing in this context. This is the choice question that we asked. Hopefully it's not too small for you to read. Healthcare professionals completed 12 choice questions like this. We asked them to choose between 4 alternatives: whole genome sequencing, whole exome sequencing, panel testing, and no testing. We gave them a description of a patient, a hypothetical patient. This was deliberately written, and quite excruciatingly so, to be deliberately borderline to force respondents to make some quite difficult decisions about which test they will prefer. The tests themselves were defined in terms of 5 attributes, so the ability of the test to identify either pathogenic mutations or variants of unknown significance, the cost of the test, what happened in terms of disclosure of secondary findings, and the amount of counselling that patients would receive alongside the test. 37 healthcare professionals completed the DCE. It's a relatively low number, although I suspect it's probably quite a significant proportion of all those who regularly request these tests in the UK. Across all of the choice questions, panel testing was the most preferred option in 2/3 of the choice questions. Again, the choices that were made by respondents indicated that uptake is, as you might expect, more likely for tests that identify more pathogenic mutations, fewer variants of unknown significance, and are cheaper. Respondents didn't really place too much value on whether secondary findings were disclosed or not, or on how much counselling patients were given alongside these tests. When we look at the trade-offs that respondents would be willing to make between different attributes, we can say that for a given test, respondents would be willing to tolerate a 36% increase in the detection rate for variants of unknown significance if this corresponded with an improvement in the detection rates of pathogenic mutations of 10%. So I think that says something quite interesting about the relative preferences of health professionals in this context. When we look at willingness to pay, respondents are willing to pay £740 for panel testing, £890 for whole exome sequencing, and just a shade under £500 for whole genome sequencing, irrespective of the characteristics of these tests, if the alternative was no testing at all. And then if we look at the willingness to pay for the different attributes of testing on top of this, we can see that they were willing to pay £120 for every 1% increase in the pathogenic mutation detection rate. And given Dean's scepticism about placing a value on variants and the detection of variants of unknown significance, Dean will be pleased to know that we did value this, and respondents are willing to pay £30 to reduce the detection rate for variants of unknown significance by 1%. So I'll leave that to Dean to comment on the value of estimating that value. The final step in this analysis was to use this information to say something about the likely uptake of genomic testing. To do this, we needed to select levels for each of the attributes, for each of the different types of tests that we felt best reflected current practice or current knowledge of the attributes of the tests. In doing this, I think we were probably slightly generous in terms of the assumptions we made with respect to what whole exome and whole genome sequencing could possibly do in this context. But even taking that into account, we found that the predicted uptake rate for panel testing was 83%. So whole genome sequencing and whole exome sequencing don't really get a look in this clinical context in terms of what health professionals want to offer to patients. So it's an example that quite nicely illustrates the fact that it's not just the preferences of patients that are important when translating these tests into clinical practice. Those of clinicians are also potentially important as well. Okay, so final slide. That was obviously a very quick overview of the current evidence base here in the UK. Given this, what evidence do we still need to be able to answer the 3 questions that I posed 15 minutes ago? The first question I asked was, how much do genomic tests cost? I think it's clear we can only give a partial answer to this question at the moment. To improve on this, we need more detailed microcosting studies in different settings, testing different configurations of testing around the UK, and taking into account things like economies of scale before we can say with any confidence that we are really approaching this $1,000 genome or £1,000 genome. I didn't really talk about this much, but we also need to think about the cost that patients incur across their clinical pathways, and that's both before and after current testing practice and the potential costs that they might incur before and after we might introduce whole genome or whole exome sequencing into clinical practice. And this is going to require us to make use of data from big sequencing initiatives like the 100,000 Genomes Project, which I think is set up hopefully quite nicely to allow us to do that to a certain extent. The second question he asked was whether these tests are cost effective. There's clearly insufficient evidence to answer this question at the moment. And there's an urgent need for cost utility analyses of these of different applications of whole genome and whole exome sequencing in both the UK NHS and wider than that. And I think if in the UK we're going to make resource allocation decisions using the QALY as the main outcome measure, then it's important that the translation of genomic tests into clinical practice is also informed by, at least in the first instance, the use of the QALY. This information is, however, just not simply available to decision makers at the moment. One of the reasons why these studies aren't being conducted is that it's quite difficult to get from the sort of health outcomes that people are comfortable discussing in terms of whole genome sequencing, like pathogenic mutation detection rates, to quality adjusted life years. And we need some better estimates of survival and quality of life gains if we're going to stand any chance of generating QALY estimates for these different tests. And then the final question he asked was, are these tests valued by key stakeholders? I only presented a snapshot of this evidence. I know Dean has done a lot of work on this in Canada. I think Dean could probably have spent 45 minutes talking about DCs that he's conducted in Canada. I think the evidence base is evolving quite nicely in this respect, but the main barrier that we're going to face going forward is convincing decision makers that this information has any value in terms of how they normally make decisions in terms of health technology assessment. At the moment, that in the UK NHS, in NICE, there's not a role to play for this information. And perhaps ultimately it might not be the case that these alternative estimates of value feed directly into the value calculation. That's obviously a big topic that we've touched on in different sessions already today. But certainly I think there's scope for information on the likely uptake of these tests that comes from discrete choice experiments and other stated preference studies to feed into cost effectiveness models, for example, and to influence or to have an impact on the estimates of cost effectiveness of these tests that we generate. Okay, I'm going to stop there. Hopefully there's a couple of minutes left for questions. Yeah.